Hello, everyone. Thank you for joining us today. My name is Rashida, and I'm one of the chairpersons at SUPTA this year. We are very excited to begin our annual teaching series today. This week, we'll be focusing on perioperative care, and we're very happy to have you all here today. Today, I am joined by Mark Burns, who will guide you through preoperative care. Mark is a fourth-year student from the University of Southampton. To make the session as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our very best to address them as soon as possible. At the end of the session, we'll share a feedback form. If you complete this, you will receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and Pass the MRCS. This session is being recorded, so the recording and slides will be shared on our Medall page a couple hours after the session, so be sure to keep an eye out for that. Now on to a very exciting announcement. So we're very happy to launch our very own learning portal, which is hosted on our website. Through this learning portal, you'll get access to practice questions, session recordings, and revision material. As a bonus, all members will get a discount code to get 10% off the Geeky Medics anatomy flashcards, surgery flashcards, and the knowledge bundle. The best part is you can access all of this for free, so be sure to head on to our website after the session to explore this. We also have another very exciting opportunity for all our attendees. Two lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form that we provide at the end of the session and enter the unique code. The more sessions you attend, the higher your chances of winning. So be sure to stay until the end of today's session and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons, England, Geeky Medics, the NTU, More Than Skin Deep, Medall, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Mark.
Hi guys. I don't know whether you can hear me. Can I just check?
We can hear you all right, Mark.
Brilliant. Hi guys. As mentioned, I'm fourth year at Southampton. I've just come back from my intercalation, so sort of in my fifth year. I'll be talking you through pre-op care. As mentioned, here are some of the partners. And this is the overview of what we're going to have a look at today. Just a general overview of pre-op medicine, a bit of the shenanigans around consenting, counselling a patient, and everything you need to do that completely. Part of the preoperative assessment, preoperative optimization, a little bit on nutrition, or a huge amount, and drugs to review, of which there are quite a few, and blood transfusion and the complications of it, which there are quite a few. Ignore the number in the bottom. I initially thought I had to make a VVOX for this, but I didn't. Anyway, so overview. So the preoperative period is, although not exactly immediately the most glamorous part of medicine, is really quite important. Very important for building your rapport. Very important too. Very important for getting some investigations done. Consenting, which, unless you want to get sued, is obviously quite important to do as well. And then assessing risks that each patient may be susceptible to in their surgery. And then, of course, in this period, we've got to do a drug review and then just generally prep and plan. I was talking with an anaesthetist just over here on the side, if you can see my laser pointer. And he sort of talked about it, about being the control of the controllable. Things can always go wrong in surgery. It can always throw a curveball at you. But the preoperative period is all about absolutely nailing down the stuff that could be, out of your control if you didn't address it beforehand, and minimize and mitigate the risks that you could come across in the surgical window. So, counselling. Patients, surprisingly, aren't all doctors, and they don't immediately know what's going on. And even if they are doctors, they may not know exactly what is going on, because they may be a doctor in a field that you aren't performing surgery on. So things you need to cover when explaining procedures to a patient. Now, this is sort of based around what you might need of OSCEs. You might see something similar on the Geeky Medic website. Open the consultation. seems kind of dumb, but make sure you introduce yourself. Make sure you're talking to the right person. That could get quite awkward a bit further down the line. And make sure they know. Make sure they know what they're here for. Because if they don't know what they're here for, then that is a bit of a worry. And then makes it easier for you to then know how much you need to cover with them. If they're very knowledgeable on the topic and they know what they're looking at, then maybe a little less detail might be needed. Perception invitation. Basically, this all means, what do they know? What about the procedure? And always ask them what they're worried about. Patients have worries about their treatment that you may not consider the main worry. And if it can be easily addressed, do address it. Many times, what do they want to know? They don't really want to know what bits you're chopping out half the time. They want to know, are they able to drive afterwards? Are they able to go for a swim? Are they able to go to the gym? And you need to be able to address such concerns pretty concisely. And then explain what is normal in a person to be going on. Explain why the surgery has become necessary for a patient, what's gone wrong. Explain briefly what's going to happen in the surgery. You don't have to go into obscene detail about each artery and vein you might be clipping or whatever. And most importantly, of course, for their side, what they must do before they go into surgery and what they must do after surgery. So remember to stop regularly. Remember to check their understanding. They aren't necessarily medical. In all likelihood, they're not medical. And so oftentimes it's worth checking their understanding so that you don't get confused, and it's a lot of information very quickly. Don't jargonify the living daylights out of what you're saying. Discuss the benefits of proceeding with the surgery. Discuss the complications of the surgery. Be honest. If you know the odds, give the odds. I'm in obstetrics at the moment, and there's endless discussion of infection risks, even though we don't give bridging antibiotics. And if need be, you can always discuss the alternatives if the surgery doesn't go forward. Surgery isn't always the answer to everything, and sometimes people aren't necessarily wanting the surgery, or then not necessarily for a good surgery at that time, okay? But yeah, it's all about just checking their understanding on repeat. And explain fasting. And explain the medications they have to stop and how to do so, which is something we're going to cover more. But this is the part of the preoperative period that we have next to no control over. So make sure that they know what they're doing to make it all happy as you go along. And finally, just wrap up. You'll have given them a lot. So if they have any more confusions, just ask for them and tell them there's no stupid questions, because there aren't. And then just address those. And, if they haven't got it first time, maybe try a different explanation, different route to get them up to speed. For your OSCEs, give them a leaflet. In real life, give them a leaflet. They'll want it. They'll have a read of it. Many people are quite interested in what's going on. And give them a little summary. That's also for you, because if you give them a summary, you can then maybe suddenly remember, oh, forgot that bit, go back, add a little bit extra, okay? And if you're not too pressed for time, ask them to give you a little summary back of what they have to do, okay? But in counselling, I roughly follow this sort of structure for any procedure. It tends to get you over the mark. Consent-wise, so what do you need to be able to do to consent? I'm sure you've been bashed over the head with this for quite a number of years at this point, but they need to be able to understand the information, weigh up the pros and cons of it, and repeat it back to you in time, they say. Which is a non-specific thing, but it basically just means they have to be able to retain the information you've given them for a period of time. Sometimes it's blatantly obvious someone has consent, sometimes it's a little bit, capacity, but sometimes it's really not very obvious that they have capacity, and sometimes it's really obvious that they don't have capacity, okay? So that's sort of the three tenets, which I'm sure at this point you're aware of. What are the types of consent? Just generally, you have an informed, an expressed, and an implied consent, okay? For surgery, it needs to be informed. You need to have quite literally told them exactly what's going on so that they know the decisions they're making, okay? The patient comes in and says, I don't worry about any of this, I just want it done. that is an express consent. You still need to tell them the risks because they may reevaluate in time, okay? Importantly, there are different types of consent form. Hilariously, for every single surgery in the NHS, there are 4. And they all come under different sort of standards of capacity that you can have. It doesn't matter if you're having, a tiny little exploratory lap chole or some enormous, Whipple procedure. That will all be signed on one consent. And these are ultimately a 1, 2, a 3, and 4. 1 being for those who are adults with anaesthetic, a nice simple one. 2 is a paediatric one. 3 is a procedure without sedation, and then 4 is best interests. So these are your your emergency surgery. Somebody's out. Note that's something to remember for the next slide. And importantly, when seeking consent for a procedure, make sure the person doing it knows what they're talking about. Don't get caught out doing something that you don't know about or don't feel confident delivering to somebody, okay? Preferably, really, consent should be taken by somebody performing the procedure or, the consultant. But as you go on, just make sure that you're never consenting a patient for something you don't understand or you don't know the risks of, okay? Because that can wrap you up in all sorts of nonsense, medico-legally. So, little case study. We've got a male. He's 23. He's been brought into the emergency department after being whacked around the head with a cricket bat. He is a GSC 7, E2MV, V2M3. He gets sent for a CT head as somebody who comes to ED with that low of a GCS after a head injury would. And you see that. Oh, as you can see, that's a nice big extradural hemorrhage. You've got that lemon shape, okay, because it's been confined by the sutures. However, there you go. Can they provide consent? And the answer is no. They've got a reduced GCS. They can't. Their voices are 2, so they're just gurgling. Not making much noise. They're obviously not going to be quite with it, so they aren't able to make a capacitous decision. But the key point here is, can you still perform the surgery? Which, this patient likely will need. They've got the mass effect, all sorts of brain trauma, damage going on there. And the answer is yes. And the reason that is because of what we're talking about with the consent form 4, okay? In these medical emergencies, they need to be getting into theatre quickly. And if they don't have the capacity, we don't have the time for them to get back to a state of mind when they can provide capacity. They may not even reattain that state if you don't go on with the surgery, and that's why Form 4 consents exist. Okay, so that you can get people into surgery when a decision is within their best interest. Okay, and there is a lot of decision making that comes with that as well, and it really oftentimes takes the opinion of multiple healthcare professionals to reach that decision. So, covered consent, covered some counselling. In the assessment, as is with all things, history, examination, investigation. History is your first port of call, examination is your next, and then your investigation is what you're going to do about what you find during your history and examination. We're going to be talking about these quite broadly because I'm not going to go through a history for an MSK history that you might have for a knee pathology or some hepatobiliary history, okay? But the general tenets of all history taking ever, presenting complaint, your past medical history with a little asterisk in there. Also remember your surgical histories. Do a systems check. I always do a systems check now. I think that's probably quite worthwhile. Medications, allergies. I don't know who's taken surgery placement here, but I'm sure a reg at some point has told you to go back and ask for an allergy. It's absolutely necessary that you ask about allergies. And previous times they've had anaesthetic, just because that's really useful for anaesthetists to know how they've handled it before. People who do well on anaesthetic one time tend to do well on it again. So yeah, these are the 3 we're going to have a little bit more of a look into detail with. And just a little bit thing with the allergies. This is based off of my local guidelines. I don't know how it is in other people's hospitals, but with penicillin allergy, you have to give them a different antibiotic that isn't, something like Kermoxiclav. And where I've been in Portsmouth, the first thing we give after that is teicoplanin. And anybody who knows about teicoplanin know that it has something like a 70. I think it's a 7 times higher incidence of anaphylaxis to it than penicillin does. So you can quite often get stuck between a rock and a hard place with prophylactic antibiotics and surgery. So it's often worth asking patients about what happened to get them a penicillin allergy on their notes, or in their opinion, was it a full-blown angioedema, anaphylaxis, they needed the adrenaline, or was it, sort of they felt a bit itchy, or they got a bit of a dicky tummy, because that's not true allergy, and actually they'll be fine to go on penicillin, which is much more preferable to going on teicoplanin. When I was in ICU and I saw a lady came in who'd had some teicoplanin, and she was on ICU. She was in quite a lot of trouble, and if you'd been able to have penicillin, that'd probably been quite the preference there. So, in a systems check, you got to go through your systems, funnily enough. So in your respiratory system, sort of questions you might want to be asking: what conditions do they have? So if it's something like COPD and asthma, how well controlled are they? Have they had any recent exacerbations? Have they had any hospitalizations recently? Somebody who is asthmatic but hasn't had an exacerbation since they were 12, you're going to be less worried about than somebody who's got brittle asthma and is having wall-to-wall asthma attacks every week. Smoking wise, you just want to know about their smoking history. It's always useful. Can they lie flat? Really useful for your anaesthetists. They have sleep apnea. If they have sleep apnea, they're likely to have a less patent airway. Cardiovascularly, hypertension. Are they going to have a heart attack on the table? When were these things? Okay. And do they have AF? In surgery, there's all sorts of risks of stroke. You're in a prothrombotic state. So you've really got to know about these conditions where a prothrombotic state is really, really much more dangerous. Okay. In terms of diabetes, never mind. Look over there. That's just some stuff. In terms of cardiovascular disease, this is a bit, academic really, but this is the sort of stuff that classes patients as mild or severe cardiovascular disease in the eyes of an anaesthetist. Diabetes, is it controlled? The main thing this is important for is insulin administration. I think the cutoff that's recommended now is an HbA1c of 69 and above. When they're that high and their HbA1c is that poorly controlled, then they'll almost immediately be put on a sliding scale insulin infusion for surgery. You also want to know how it's managed. As we'll get on to later, that's really important in terms of drugs, what drugs you might stop, and when. Okay. In terms of your kidneys, you want to know, are they on something like dialysis? If they're on something like dialysis and you're shutting down a few more of their systems by putting them under anaesthetic, you might want to get involved, might want to call up your ICU department and see whether this might be a patient that's fitting for them. You want to know about other conditions. You want to know about their chronic kidney disease if they have it. Neurologically, have they had any previous strokes, and can they swallow? That's really important from an anaesthetic view. If they cannot swallow, they're at higher risk of something like an aspiration pneumonia. They may have more troubles taking down an airway adjunct. Do they have epilepsy? Are they prone to having delirium? That's an absolute classic one for your CQ situations. Surgery is a massive insult. They're much more likely to go into a delirious state. GI-wise, do they have GORD? This is, again, as you'll hear me repeat over and over again, The problem with reflux is you're refluxing, you're more likely to aspirate and get an aspiration pneumonia, which is all sorts of trouble. Again, ask them how they manage it. Alcohol-wise, always worth doing an alcohol screen no matter what you do. But equally, with surgery, that's a long time where they can't drink. Are they at a risk of withdrawal in that period of time? Because you don't want somebody to have a seizure while under the knife, musculoskeletally, what their spine's like. You need to get an airway past them. If they've got great big changes in their spinal cord, then they may struggle to tolerate a tube. And also, I've just chucked it in here because we don't really know about teeth particularly, but how are their teeth? You're going to be putting if they're going on general anesthetic, you're going to be putting a great big tube through there and you might knock their teeth. And then gynecologically, I think this is a really important point to make. Could they be pregnant? Okay, this is absolutely 100% important in all things. Could they be pregnant? Anything you do, you don't want to potentially be putting a fetus at harm. Okay. Investigations wise, again, differs between operations. This is a very sort of broad look at these things. And once again, differs between patients. There's not one set list of things you should be doing every single time for every single patient. You'll drive your hospital crazy with the amount of investigations you're ordering, okay? It's all about picking appropriate investigations for appropriate operations and appropriate for that patient every single time. These are the ones I'd consider. ECGs, okay, just threw that out for a little bit of fun. Those of you there, keep yourself interested, try and figure out what that is. It's not too difficult. The key thing is you'll give it to all people who are over 80, pretty much everybody over 60 half the time, and anybody with something going on with their heart and their kidneys, okay? Bloods, rather important when you're going to be cutting somebody. You want to check what their baseline is, and especially, you want to know about their anemia, okay? If somebody's bleeding and they haven't got much reserve blood to give, that might be something worth correcting before you take them to surgery. Pregnancy test. Again, I'm going to harp on about this. This is very important. All women of reproductive age is a bit of a broad term. I think some, I've seen some cutoffs between 12 and 65 or something, but use your intuition there, and don't be afraid of doing a urine dip and check for a pregnancy test. Okay, it's not a mistake you'd like to make. Blood pressure wise, essentially, in hospital, when in the community setting, a high blood pressure is a great big problem. In the hospital setting, a high blood pressure is slightly less of a problem. If it's going as high as something like 180 over 100, just wait. Okay, you need to get that under control before you take them to surgery. And chest X-ray. There's some really important situations to order these for. Are they going to ICU? Those of you who have been in ICU, patients a lot of the time, receive regular chest X-rays to check their progress and check that their lungs are okay and they're not getting any new problems, especially with being intubated. There's all sorts of lung pathologies that are linked with those as a side effect. And it's really important to understand what somebody's lungs look like before they go into surgery to see if you've developed a problem, created a problem, and then to see how that problem improves with time, okay? Worthwhile doing when they're older, and for things like a neck of femur fracture, they can be routine. And that's because, I don't know how many people know about this sort of stuff, but when you break a bone, there's a high chance of you having a fat embolus, and throwing off an embolus, that can go to your lungs and cause all sorts of damage. So it's worth having a chest X-ray to see what's going on, okay? And yeah, that's just AFib for those of you who are paying attention up there. So, preparation for surgery. The main thing that people want to do are the fasting periods. As you'll see in the bottom, unfortunately, you've sort of got your answer already. We do the fasting periods to mitigate the risk of an aspiration pneumonia. Now, you'll see on your X-ray, you can do your full rundown of how it goes, but the key thing I want you to look for is right here. Okay, you've got this nice little area of consolidation, which is an aspiration pneumonia. And the reason we do a fasting period is because when we aspirate, it goes down our lungs, causes all sorts of trouble there, and so you fast so that you've got nothing in your stomach for you to put into your lungs. Okay, so it's important that the stomach is as clear as it can be before you go into theatre where you're at a higher risk of doing that. So non-clear fluids and food, stop 6 hours before surgery, at which point you start your sip until send. Now, by the book, that's you stop all clear fluids 2 hours before, but that's sort of a bit of a lie. The sip and send is sort of a more normal thing to do, where they're just allowed to have small sips of water until they go. With diabetics, this is sort of another point. They're particularly complex patients, and we really need to be careful of them going hypoglycemic. So whenever you have a diabetic on your list in the future, as I'm sure you'll all be surgeons, you've got to make sure that you're aiming to get them done first thing in the morning. Okay, that just makes it a bit easier, and then it lets the ward know that they've got a diabetic patient coming back from surgery, and they can get on top of that patient nice and early. Okay. Other points of preparation for your surgery: you got to have an airway exam. The reason we do this is, we've got to find out whether there's going to be any problems securing their airway once they're asleep. Once they're asleep, they stop supporting their airways, okay? And you don't want any nasty shocks before you go in. There's a few ways they do assess this. You've got things like the Mallampati score, which is all just to do with the amount of hard and soft palate that's visible, okay? 1, that's the easiest, a nice clear route down. 4, that's the hardest, not such a clear route down, okay? And that'll be a harder airway to intubate. You've also got other things like this, which are used to determine how difficult a patient might be to intubate as well. Okay, so it's through different levels of complexity when assessing airways. You've got sort of the eyeball test, as it were, and a more academic view of doing these things. Okay, airway adjuncts. So this is sort of shifting away from preparation, sort of thinking about how you might secure the airway. So you've got all sorts of fun little bits. This is my personal favourite. So you've got things like your manoeuvres. That's the first port of call. So you do your jaw thrust, and you can do your chin lift. The jaw thrust is the one you most commonly do, and that's where you're just pulling the jaw upwards and outwards, and that just opens the airway. In terms of kit, so all the kit is about finding different distances and routes so that air can get from there, but from these 2 slots through down here, okay? So you've got your Goodell's, which you pop in your mouth, okay? These are really good bits of kit, but patients do not like them so much when they're waking up. They're quite bulky, they're in their mouth, and they don't tolerate them so well at that point, but they're very useful. You'll see lots of patients with them in. And they just pop round here and just keep that tongue off the back, okay? And that lets the air just pass through nicely. Other things you got, okay, so you got your nasal pharyngeal airway. So these come in here, pop down there, down the back of your nose, and find your airway down this way, okay? These are much better tolerated in patients when they're awake, okay? They're pretty uncomfortable as they go in, but once they're in, they're fairly comfortable. So if your patient doesn't like these while they're waking up or while they're awake, pop over to one of these, okay? Next up is the eye gel. The world's easiest thing to put in. If you get the chance to put these in theatre, they take about 4 seconds. They're almost foolproof. The idea is you just pop them in, they curve round, and then this section here just sits over this and forms a seal there, okay? And you can have general anaesthetic and ventilation done just purely through these. Finally, it's the main thing, the endotracheal tube, okay? That comes back down through here, okay, and it forms a cuff here, which keeps the airway patent and allows for the delivery of air through to the lungs, okay? But yeah, these are your key adjuncts. Manoeuvres first, if you're in a rush, you can pop one of those in. If they don't like that, go to that, and then from that you can go up to there, and eventually need to call an anaesthetist to pop one of these in. But that's essentially all you need to know about airway adjuncts. Now, assuming you've done everything before, you've done your history, you've done your examinations, you've done your investigations, you check their airways, ultimately you'll be left with your ASA, okay? If you're an anaesthetist, okay? This is the ranking, and it basically tells you how tricky a patient might be during the surgery from an anaesthetic point of view. It's a key part of your surgical safety checklist. For those of you who've been in theatre, you've got your sign-in, which is when is before the patient goes under anaesthetic. You've got your timeout, which is before skin incision, and then you've got your sign out, which is when the patient leaves the operating room. Okay, and you'll hear them throughout surgery go ASA 2 or ASA 1, ASA 3, and that's just to talk about how tricky a patient this is surgically from a medical point of view. Okay, and that's your final point. So, Rashita, this is the first poll. I don't know whether it's open yet. But so this will be our first knowledge check. How long should a patient abstain from clear fluids before elective surgery? And fingers crossed there should be a poll open for you to answer.
The poll is now live. I will read out the responses in just a second. Okay, so 82% say 2 hours before.
Wonderful. Yep, you've nailed it. Bosh. 6 hours is the other cut-off point. Remember, 2 hours is if you're given the option in MCQ at uni, that's the option you'll go for. But often with patients, you just let them sit with clear fluids until they're cooled, because it's awfully nasty having a dry throat. But yeah, and 6 hours is your cut-off point for food and non-clear fluids. Another little point, this is what clear fluids are. You got your water, your juice without bits, coffee and tea, but without the milk, okay? So, drug review. We'll fly through this because it's really quite dry. But the key ones, exams especially, are your combined pill, your anticoagulants, your antihypertensives, and your metformin, okay? So, your combined pill. So, the reason we worry about this is because of the VTE risk. I'm sure those of you who've painstakingly learned your UK MEC criteria know that absolute contraindications when people had recent strokes, okay? And in a surgical setting, somebody's immobilized for a long period of time, they're in this very insulted state physiologically, they're at much higher risk of clot following, okay? So here you go, you've got the stasis, you're going to have damage, and you're going to have some changes going on that promote coagulation. So you've got to make sure you're off the cock, because you've got that estrogen working on your liver, which increases synthesis of certain clotting factors, okay? These are the ones you want to look out for. You've got inhibition of antithrombin 3, which does what it says on the tin. It's antithrombin, so that's a clot buster. But it increases the prevalence of fibrinogen and factors 7 and 10. So you're in this higher coagulable state. I've just put as a little note at the bottom here. They're off contraception. Be ready to prepare to counsel on that front, okay? When you're taking someone off any form of contraception, they may not know how to then handle that, okay? So advise about condom use, okay? And take that moment to let them know that if they have sex from this period of time, they may become pregnant. So, how do we manage to cop around the surgical period? We stop it 4 weeks before, okay? I've just also put in here about estrogen, okay? Basically, the problem is estrogen and the effect that has on the liver, okay? So we stop it 4 weeks beforehand to try and get the body back to normal. Anticoagulants, I've been a little bit naughty here, but the key different types of anticoagulants we've got warfarin, we've got a DOAX, we've got fondaparinux, enoxaparin, and we've got antiplatelets, which aren't technically anticoagulants, but I've just chucked them in here. because they're also something that you need to be aware of. So, why are anticoagulants a problem in surgery? You bleed, and we'd rather you didn't, at least not too much. So, if they're on an anticoagulant, they're also likely at a higher clotting risk too. So, if you take them off the anticoagulants, you then tip back over into that situation where they might clot more. And so, you need to properly assess the severity of their clotting or their risk of bleeding. So just a quick little terminology, you'll see this all the time. Bridging. It's a term we use where you're sort of working them up to that surgical period. You usually use a low molecular weight heparin. And basically it has a much shorter half-life. So it allows a really, really easy control of someone's bleedability, as it were. So yeah, you've got your warfarin, you've got your DOACs, which are your Zabans, and you've got these fellas, okay? So warfarin, I've linked these from some guidelines. You've got your low risk people, and what I'm saying here is have a look for the common threads in all of these, all right? So you go through your different risks. Here at your very high risks, you see, like, you're really thinking you don't even want to give them surgery. But the key thing you'll be seeing throughout this is stop the warfarin 5 days before surgery, okay? You're trying to get INR to normalize. Equally in here, you see you've got the dalteparin, which is the low molecular weight heparin, okay? And that's used to bridge. And it's all about keeping them in appropriate INR range, okay? If they're floating around these levels, you want to be in touch with the hematologist, okay? It gets very complicated with all this, and when you start talking about using antidotes or reversal agents, it starts to get very confusing. So keep everybody informed the whole time and stop your warfarin 5 days before surgery. That's the key thing, 5 days before. With your DOACs, way easier. So if they're low risk, you probably don't even need to discontinue them, okay? These are less problematic, and which is why we're shifting over to them. Warfarin is becoming an increasingly less sexy drug now that we have the DOACs, okay? So each one has slightly different ways they're handled and where they might be withheld, okay? So, day before, but if they're at a higher risk, okay, then it can become more problematic, all right? Another point here again about reversal agents, they get very tricky. So for dabigatran, you've got idarucizumab as your reversal agent if you need it. That's one I always see in the MCQs. And for your Zabans, okay, Factor XA is your reversal agent. Fondaparinux and Fragmin. So these are essentially low molecular weight heparin. So slightly less of a worry, okay, but still worthwhile knowing. As you can see here, you're just trying to wean them down until on the day of the dose you admit it, because it's short acting, and if it's short acting, hopefully it's cleared. They're at a slightly lower bleed risk, and then you can restart their dose to take them back up to their appropriately thinned level. Antiplatelets wise, so remember these aren't anticoagulants. I've been a bit naughty. And these are handled a bit case to case, okay? Just to remind you, okay, anticoagulants is sort of on your veiny side of the body that these work, whereas the antiplatelets are more on your arterial side of the body where they work. But when do you stop them? So aspirin and prasugrel, you want to stop those 7 days before surgery. And clopidogrel and ticagrelor, it's 5 to 7 days before surgery, okay? But yeah, just for completeness. But remember, these aren't the same. Yeah, I know it always gets really confusing remembering what the difference between them are. Just remember, anticoagulants for the blue side, antiplatelets for the red side. In terms of antihypertensives, it's the usual culprits. Your ACE inhibitors, every single time, if you're ever in trouble, if anything's a side effect and you've got nothing else to put in your multiple choice questions, just put ramipril, okay? Remember what's going on in your system, okay? The problem is with these is that they vasoconstrict. They inhibit your ability to vasoconstrict. Okay, you're inhibiting ACE. You can't get your angiotensin II. You can't get your vessels to constrict. Okay, and therefore your body's less reactive, and it can respond with less skill to the insult of surgery. Equally, if you go hypertensive, those of you who know your causes of AKI, hypertensive can lead to essential hypovolemia. It effectively works like that, leading to hypoperfusion of your kidneys. Kidneys don't like that. They go into an AKI, and then in AKI, ACE inhibitors and ARBs are even worse. Okay, so these buggers, you want to get rid of them, okay? So when do we stop them? 24 hours before surgery, all right? But yeah, my piece of advice here would really be, if you're ever in trouble in an exam and you don't know the answer and ramipril or another ACE inhibitor is there, that's not a bad option to go for. Metformin, so for diabetes, mostly type 2 diabetes, and also gestational, but this is a usual culprit. And the key side effects of metformin, you've got your GI upset and your lactic acidosis. I'm sure many of you know lactic acidosis is a theoretical side effect more than it is a real side effect. It's pretty damn rare, but it's something we still worry about. And the worry is that in surgery you're at a higher risk of lactic acidosis. The reason I sort of say it's a bit of a nothing side effect is you'll see with how we handle it. If it's taken once daily or bi-daily, we don't change anything about the prescription of it. You know, that's how minimal a risk this lactic acidosis is, okay? However, if it's taken 3 times daily, we do omit the lunchtime dose, okay? But that's the only change. It's a pretty minimal risk, but it's still one that is accounted for. So, next poll. Which of the following drugs is most likely to be stopped before surgery? Bisoprolol, bendraflumethiazide, amlodipine, or ramipril? Hopefully you've been listening to me for about the past 2 minutes.
%96 have said ramipril.
Brilliant, you've listened to me. Every time, if you're stuck for an answer, go for ramipril, okay? It's almost always your answer. I mean, it's not literally almost always your answer, but if you're out of options, go for ramipril, okay? Blood transfusions. This will probably be a bit of a flying visit, but we'll just go over a little bit of the basics, and then we'll cover some of the complications you can get through having a blood transfusion. So, why do we give blood products? So, they're colloid fluids, which means they have a protein content. Those of you who are really into your physiology, that means you've got it contributes to your oncotic pressure, which helps you retain water within your vasculature. You also give them for really specific reasons, so we'll talk about it in a second, but replenishing your clotting factors, improving oxygen carrying capacity. The problem with fluids is non-blood fluids are that they don't contain any red blood cells, and therefore you can pour on as much fluid and as much fluid as you want, but all you're doing is ultimately diluting out your plasma and your red blood cells. So before you give blood, you want to cross match, and we want to group save, okay? And there's different instances in which we do each. So cross match is simply, for higher bleed risks, and group and save is for those who are less likely to need a transfusion. But it's, as we say with surgery, it can be pretty unpredictable. So even if it's unlikely, there is a potential risk, and it's rather nice being able to go to the fridge and get the correct bag of blood if you need it, but you don't necessarily need to have it on hand like you would in a higher bleeding risk surgery, okay? In terms of different blood products, there's a list as long as your arm, frankly. You've got whole blood, you've got packed red blood cells, you've got your platelet-rich plasma, got your platelet concentrate, FFP, cryoprecipitate. They all do slightly different things. and they all address slightly different problems. Things like, platelet rich. If it's platelet rich, you're probably giving it for someone who doesn't have many thrombocytes. Okay, so if someone who's thrombocytopenic, you're looking more at these fellas to give. Okay, but yeah, group and save is ultimately for finding ABO and rhesus compatibility. Okay, which I won't bat you over. I will bat you over the head in a minute with. Also, just quickly, how do we group and save? There's just a few little bits of slightly boring housekeeping, but you need to have valid samples. Okay, so if someone's recently had a transfusion, their sample for a group and save test is valid for a much shorter period of time, and you always need 2 samples to verify your results. That can be, if they've had 1 sample taken and never had a transfusion, and it was about 30 days ago, that can be fine. That's fine. That can be used as a sample. You just need to take another blood sample for another check. Okay, make sure you do it pre-op. Seems a bit obvious, but get these things done early, because you don't want to be rushing around trying to figure out what blood you can put in someone while they're in surgery. So you definitely can't tell that I did a biochemistry degree last year. This is what ABO is. Okay, ABO is simply all about what antigens are on the surface of a red blood cell. Okay, so I put selfish and selfless here. With your ABs, okay, you've got both antigens on your cell surface, so therefore your body doesn't produce antibodies to either A or B. So therefore these guys can take everything. Okay, Group O, they're brilliant for donating because they've got nothing on the outside, but they're brilliant for they're rubbish at receiving blood. Okay, because they've got no antigens, they produce antibodies to both B and A. Okay, that's all ABO means. So if someone has an acute hemolytic reaction, which is when, okay, imagine in an O you've just given them a bag of B, you get fever, you'll get abdominal pain, and they'll go hypotensive. Okay, that's all because you're getting an immune reaction to the blood that's come in. Okay, the antibodies have recognized it and they're trying to clear that blood because they don't recognize it as themselves. And what you need to be doing here is stopping the transfusion immediately. Okay, and then what you want to be doing next is supporting them. Okay, hypertension, I'm sure you know, it causes all sorts of problems in all sorts of people, and so you want to get that blood pressure back up so they can keep perfusing their kidneys, keep perfusing their tissues, and not cause any ischemia elsewhere. Following that, your patients survive because you've attended this talk. Do the paperwork and have a look through what's happened. Okay, mistakes happen. I'm sure you've heard this before, but mistakes do happen. You need to find where in the chain the mistake was made that the wrong bag of blood has been administered to somebody, because somebody basically needs to be educated on what went wrong and the severity of the problem. Okay, but yeah, principally stop the transfusion and support them through it as much as you can. Anaphylaxis. So it's a bit of unknown etiology, but it does happen. I've heard there's multiple theories running around. So yeah, there's theories about, when someone donates the blood, they might have had a Snickers in the morning, and so therefore there's peanut floating around in their blood, and then you give it to someone with a peanut allergy, and that causes the anaphylaxis. All right, but there's all sorts of etiologies for these sorts of things that are thrown about. So somebody is anaphylactic. It's the usual things again. They're hypotensive, they're short of breath because their airways are swelling. Okay, they've got wheeze because their airways are swelling, and they've got angioedema because, in the context of anaphylaxis, your vessels go all leaky, and that leads to fluid just flooding out of them and exploding those tissues open. Okay, how do we manage anaphylaxis? No gold stars for knowing this one. Stop the transfusion, give them adrenaline quickly. You also want to do an A to E check, and you want to do that quickly because, as you see here, you're going short of breath, you're wheezing. You really want to make sure that airway's working. Okay, if their airway starts to fail and they're desatting, you need to be considering intubation pretty quickly. All right, you want to get that jaw thrust on. You want to use those airway adjuncts we talked about, and you want to help them through that while you're supporting them and getting the adrenaline on board. A Charlie. So what is a Charlie? Transfusion related acute lung injury. This is another one with a slightly wonky etiology, but the idea is that you put blood into somebody, and due to some reaction going on with neutrophils or whatever, it causes loads of fluid to just seep out of your vessels and onto your lungs. So, and you can see that here, all this fluid on the lung. And how does a Charlie present? They're short of breath, they've got a fever, and they're hypotensive. We've got another hypotension situation here. The key finding here, you've got all these infiltrates, okay? Now, the problem with Charlie is, okay, you stop at the transfusion, you support with oxygen, but the problem with the Charlie is it looks very similar to something else called a TACO, which we'll talk about in a second. And the key thing you want to be looking for when trying to differentiate these, okay, is that state of the hypertension, okay? In a Charlie, they'll be hypotensive. In a TACO, as we'll talk about, they'll be hypertensive. But once again, stop the transfusion. They've got loads of liquid on the lung, okay, so you want to be giving them lots of oxygen to make sure what blood is in contact with the alveoli is picking up oxygen, and then support them through it. A TACO. So this is a circulatory overload. Essentially, we're just pumping way too much blood into somebody whose heart either can't manage it or is just doing it really quickly. This becomes a particularly problem in a heart failure situation. So you get blood backing up. Anybody knows left heart failure up into the lungs, you're going to cause all sorts of problems. So as you back up, your hydrostatic pressure intravascularly is going to increase and increase and increase. And then as a result, fluid is going to leak out into your interstitium, okay? And you're going to get fluid on the lungs again. Now, I'm sure this feels a bit deja vu-y. It seems quite similar to a Charlie. But as I mentioned, you get hypertension instead of hypotension, okay? Because of Charlie and however it works, you just have fluid leaking straight out. It's more of a compromise of the structure of the vasculature, okay? Whereas with a TACO, it's a compromise of the amount of blood you're putting in. So you need to have a high pressure within your vasculature to push that fluid out. How do we manage a TACO? Again, stop the transfusion. I'm sure if you become more competent and the symptoms are pretty mild, you can just slow it. But you want to get those fluids off as well. Okay, so consider something like a loop diuretic to get them off, because you want to minimize the damage you're doing to that lung, okay? And you want to get them oxygenated again. So the final poll. Patient develops hypertension, abdominal pain, shortly after starting a blood transfusion. What is the next step? Do you continue the transfusion at a slower rate? Do you administer the diuretics? Do you stop the transfusion immediately? Or do you order a repeat cross-match?
Percent says stop the transfusion immediately.
Yep, that's the one. So what we've got here is we've got a acute hemolytic reaction, all right? You've got that pain because you've got all the exploding red blood cells in your vasculature, okay? And that's quite painful for a person. You've got hypertensive because you've got that, you're hypotensive because you've got an acute reaction going on, so your vasculature's gone all leaky and letting fluid out. And so what you want to be doing is stopping that transfusion. You want to stop the problem. Well, you want to stop the thing that's causing the problem, okay? That is my main takeaway fact.
Right. I think Mark has had some technical difficulties here, but I think we'll continue. He did finish his session, and that was really amazing. I hope all of you found that helpful. Before I carry on, I'd like to invite our director, Connor, who will also talk to you about the Learning Portal.
patient, doing a drug review, and then when you're giving blood, keep certain differentials top of your list, all right? Your Charlie, your TACO, your acute hemolytic reaction, and then hopefully you should be cushy. Ultimately, any questions from there? And there's some references.
Thank you so much, Mark. I think we lost you for a little bit towards the end then.
Oh. Where'd you leave? Where'd you lose me at?
It's okay. We caught up midway through your wrap up, but we just lost like 30 seconds. But I think okay. We got the gist.
Well, I'm sure you got the idea.
Yeah, really excellent session, Mark. Thank you so much.
No worries.
For everyone else, I just my name's Connor. Before we go on to the questions and answers bit, I'm the director for SUPTA. I just want to show you guys the learning portal, so you guys know where to go after the session. So I should be able to share my screen. Yeah, you guys can see that. Okay. So this year we've got a learning portal set up, which includes lots of catch-up materials, including recordings of the sessions, multiple choice questions and stuff like that. There's one already set up for Mark's session, so you can go straight after this and start recapping, or if you want to come back at a later date. The way you access it is by going to supta.uk, which is our website, and you click Join Now on the homepage. It's going to ask you to create two accounts, and you can use the same details for both. It's just an annoying quirk of the website host that we're using at the moment. But when you do log in, you'll be presented with your learning portal page, which is this, which keeps track of your progress as you learn. You can click Learning Portal, and these are all the sessions which SUPTA are running throughout the year. We can see here preoperative care is Mark's session. You can click that. We'll have a recording of his session come up at the top of it, and there'll be all these helpful revision materials to go along with it. Some nice bullet point summaries of everything that he's talked about. And then at the very end, we've got some multiple choice questions specifically related to the session, which include your little descriptions and things like that to go along with it. All the content which is on here has been reviewed by our anaesthetic surgical patrons, so it's all accurate and good to go learn from. As you go through the portal, it will track your progress, so you can keep track of how you go as you go along. And we've also got a dedicated multiple choice question thing, a bit like PassMed. At the moment, we've only got a small number of questions in, but as every session happens throughout the year, we'll be adding more and more questions to the bank, so it'll be getting bigger and bigger. There you go. Should be fairly intuitive. It's free to use. We just want you guys to go and play around with it and give us some feedback, and we'll build on it and adapt it as the year goes on based on what you guys tell us. That's everything I wanted. Thank you again, Mark. I think we're going to do a little quick question and answer, and then we'll leave you to it.
Okay.
Thank you, Connor. Hopefully that convinces all of you to get a membership. If anyone has any questions, please put them in the chat, and I think, Mark, you can see the chat as well.
Yep, I'll just stop sharing. Fingers crossed.
Okay. I don't see any questions at the moment in the chat, so just a couple of final bits. So we will be, the feedback form is available in the chat. Don't forget to fill it out to receive a certificate, as well as the discount codes to Teach Me Surgery and pass the MRCS. I've also released the Google form for a chance to win pre-access to the Geeky Medic surgical flashcards, as well as the OSCE stations. The link for this is available in the chat. Our next session is tomorrow, and that will be on post-operative care. So we'd love to have you guys join us again. This is at 6:30 p.m. tomorrow once again. Make sure you follow us on our social media platforms, the links for which are all available in the chat. Through this, you will be able to receive updates on the upcoming sessions. We have also posted the additional SPAs on our learning platform, so definitely check those out. We hope you found today's session helpful and engaging. Thank you once again for joining us today, and we'll see you all tomorrow. Thank you, everyone.
Rashid, can you share the feedback form again? Just because some people are asking for it.
Yes, I will do that.
Thank you.
I don't think I put the unique code in the message earlier, but I've sent it now in the chat. Hopefully all of you can access that, and I have sent the feedback form in the chat once again. All right. Thank you, everyone. Bye.